Chloride is the major extracellular anion and works closely with sodium to maintain electrical neutrality. It primarily exists as sodium chloride or table salt and hydrochloric acid in the stomach. When evaluated alongside bicarbonate, chloride gives us valuable insight into acid-base balance. In fact, shifts in chloride often mirror changes in sodium, but can also highlight specific metabolic disorders. In metabolic acidosis caused by bicarbonate loss, chloride levels increase to maintain neutrality. Aldosterone also affects chloride by promoting sodium reabsorption, with chloride following. Because of this, chloride plays an indirect but important role in osmotic pressure, hydration, and acid-base balance. Think of it as the balancing partner to sodium and to bicarb. We've listed the normal chloride levels here in adults. Children and newborns run slightly broader ranges, with premature infants at the highest. Critical values are less than 80 or greater than 115, and abnormalities outside these ranges can indicate significant fluid or acid-base disturbances that require prompt attention. Chloride on its own doesn't really tell us much of a story, but when interpreted alongside other things, it's really useful. It helps interpret and evaluate hydration status, acid-base disorders, and renal function. For example, hypochloremia with low sodium may suggest overhydration, versus hyperchloremia with metabolic acidosis might suggest a renal tubular acidosis. It really is a supporting player in clinical interpretation. Several factors can alter results. Medications listed here can change, increase, or decrease. Because chloride often parallels sodium, clinicians must consider both lab values together. And isolated chloride abnormalities are rare and they should be interpreted in the broader metabolic context. No fasting is needed, and it utilizes the same tube that you can use for a full comprehensive metabolic panel. When you have high chloride or increased chloride, you have hyperchloremia, and it's seen in dehydration, excessive saline infusions, metabolic acidosis, or renal tubular acidosis. It could also occur in Cushing's syndrome, kidney dysfunction, or eclampsia. Clinical symptoms could include weakness, dehydration, and signs of underlying disease. Since chloride shifts often follow sodium, hyperchloremia usually points to a systemic fluid or acid-base imbalance. Hypochloremia or decreased chloride often reflects overhydration or dilutional status, such as syndrome of inappropriate secretion of antidiuretic hormone or SIADH, or even CHF. It also occurs with vomiting, gastric suction, chronic diarrhea, or metabolic alkalosis. And endocrine disorders can, like Addison's disease or diuretic therapy, can also contribute. Symptoms can include muscle weakness, twitching, or confusion, though they're typically linked to whatever the underlying cause is. When we come back, we will look at potassium.